Okay, well, good afternoon, everyone. It's my pleasure to be here with you and talk about thoracic trauma, which is the third part of our lecture series today. I couldn't help but notice there's a lot of people in here, and it's more than we would usually let in, but what the hell, we'll just all get along with each other. It did remind me, though, of one situation in my life that some of you may have shared. My first day in undergraduate work, knowing I wanted to go to medical school. So I knew that, I had to get good grades in chemistry. That was very important. And in my first year, I was at Hopkins, and there were 550 people in my class. 350 were pre-med. So you can imagine the competitive atmosphere that created. Well, the first day of inorganic chemistry, the professor walked out, and he probably looked at something very much like this. And he just put his head down and he looked up. He said, after the midterm, there'll be seats for everyone. And he was right. There were plenty of seats after the midterm. So we have that test ready? Okay, we're not going to do that. Okay, so anyway, let's get started. We have a lot of material to try to cover. I'm going to work from the outside in. We're going to talk about chest wall trauma just a bit. And all these topics are going to be just hit upon because we really don't have such a great amount of time. We'll talk about lung injuries, pleural injuries, and we'll move on to the major arterial system in the chest, specifically the aorta, which is the big bad boy that we have to worry about. A little bit about esophageal injury, which actually is so uncommon it probably doesn't deserve a great deal of attention, but we'll mention it. I will talk a fair amount about major airway injuries, which we can do a lot about diagnostically. And then if we have time, hopefully I'll be able to talk about cardiac and pericardial injuries. All right, so let me start you with this case. It's an entity you may not know about. This entity was described in 1980 from the orthopedic surgeons at the Shock Trauma Center where I work. And you'll notice from the chest radiograph that we have a number of fractures of the scapula, clavicle. There were rib fractures here. And even more interestingly, if you look at the reformatted volumetric image, you can see that the scapulae are markedly displaced laterally. And then if you look at this image of the vascular structures, you can see that the axillary arteries are both occluded. Okay, now this is something called scapulothoracic dissociation. It's an entity that a lot of people aren't familiar with, but certainly occurs in major trauma. And its import is, of course, recognizing what can be active bleeding in the subclavian or axillary arteries. So here are the major features of this entity. It produces a 4-quarter amputation, which is closed. The skin is intact. There's a huge amount of edema and hematoma over the shoulder, but it's not always appreciated clinically. It's a traction injury. Something pulls on the arm. Probably the most likely scenario is the arm is sticking out of the car. In case you drive this way, the arm is sticking out of the car and something comes along in the other direction and decides to pull it out. Nerve innervation of the arm is usually interrupted. There is almost always major vascular injury. The fractures of the extremity you've seen, the hematoma you appreciate, and the lateral displacement of the scapula. All of these typically fit together, and it's a very clear-cut injury. Unfortunately, assuming you take care of the bleeding, ultimately these patients have an insensate, non-functioning arm, and about 40% of them at least come to total amputation. Here's just one more example of that. You can see that the scapula is way out here laterally. It's not superimposed over the chest at all. There is a great deal of soft tissue density, which we're seeing. If you look at the volumetric image, you can see how the scapula is completely displaced. The clavicle is avulsed from the acromion. And then in this patient, we have active bleeding into the axillary region, which obviously makes this an emergent situation to diagnose. I'll give you a moment to look at this one. It's not common, very important to appreciate. And hopefully you'll recognize that the clavicular head is posteriorly dislocated. And I'll give you some more images of the same thing.